So this is, again, I will say the gold standard. Now, why do I say the gold standard? Now, some of my colleagues, I tell them, just this morning and last night I was talking about, end block removal on my drive to work, and one of my colleagues, my plastic surgery friends, is like, what do you know about end block removal? And I said, I will prove it to you. Just tune in tonight or just listen to the video tomorrow, because we have to look at evidence. We have to look at proof. If I go pull up a plastic surgery textbook right now, we can look through each and every single page. We're not going to find a book chapter on plastic surgery / breast implant illness, standard of care. This is what needs to be done. And as you will see, what could be better than removing it en bloc? Really nothing, because you've removed it the best way, and you will understand shortly why. So the silica, the microbleed of the breast implants, stay in the biologic capsule. The removal of the implant alone leaves behind the silica, as you will see, the implant-based material, because it has bled into the capsule. The continued toxicity and the residual disease remains behind, with this perpetual burden and the insult to the human body. And then this exacerbates and fuels this immunological response, and this trigger continues. Yeah, you may have the implant out. Guess what? The trigger is still there, because all what you need is a small amount of silica, and the body itself is going to keep fighting that foreign body in an effort to protect itself. And then this ultimately leads to an inadequate relief and continued misery for the patient. So, as you can see on the date right here, I just did this on 6/11. If you look at final diagnosis, dense fibrous cyst wall with synovial metaplasia consistent with implant capsule. Metaplasia means that the cells have gone haywire, but second line, surrounding benign breast parenchyma with scant refractile polarizable material consistent with silica. So this is the capsule that I've sent to pathology. It has silica in it. What would happen, and I ask myself, I ask the medical students, I ask every single person who it may be, general surgeons, other plastic surgeons, if I removed just the implant and I left the capsule behind, guess what am I going to be leaving behind? Silica. That's, if you ask me proof right here, you have to remove the capsule. Because if I had left that silica inside the chest, you're leaving part of the implant behind, if you will. So again, proof is right here. Silica, silica. Breast implant capsule must be excised. This is the reason. Why? Now, I will tell you, I'm learning from my colleagues. I'm learning from my patients. I remember when I went to medical school, the dean of the medical school said, the good doc is the one who's always learning. Medicine 10 years ago is very different than what it is now. 10 years from now is going to be very different. 20 years from now is going to be very different. Medicine in the 90s, very different. And so the point here is, at the end of the day, no matter what, this is firm, this is rigid proof, and this is undeniable. And so this is the reason why the capsulectomy, i.e. removal of the capsule, along with the implant en bloc, is the best way to go. There is no other better way. If there is, I ask my colleagues to call me and I will listen in. So what is a total capsulectomy? So this is the next level down, if you will, where you're removing the capsule and you are essentially removing the implant, but not necessarily at the same time, or you may have a break in the capsule such that there might be some spillage of the internal aspect of the capsule and the implant. So basically, this may lead to ultimately spillage of the internal capsular contents, as you will see. Now, my goal for every surgery is to do en bloc. Am I successful each and every single time? No, as you will see shortly, because you never know. I will tell you, I never know what am I going to find till I go in. The first question I ask my patients is, who did your surgery? Because I want to make sure it's the standard of care, an ASPS board certified surgeon who did it underneath the muscle preferably, because you have more predictable results and the better outcome ultimately, if you ask me. But there are many, as you will see shortly, plastic surgeries, especially breast augmentations that are done by non-plastic surgeons, non-ASPS board certified, which is ultimately leading to more problems, as you will see shortly. So the surgeon removes the implant with a capsule that may have been torn in places during the meticulous dissection, which certainly can happen on the chest wall. You don't want to compromise the patient's health or essentially leave the capsule, but you can essentially very carefully remove the capsule or the diseased part, because remember, you can remove the capsule because it's hard. If it's abnormal, you can remove it. You can scrape it off such that the capsule that sometimes, even in the best of the hands, 100% cannot be removed because of the patient's safety. Then you can at least remove the burden and just be upfront with the patient. You know what? I tried my best, but I didn't want to compromise you. You certainly have that challenge, but you can, I will tell you, still remove it safely. Because, for example, if I'm on top of the chest wall and you have a muscle, and I know right underneath the muscle is the lung, I can go ahead and, with my headlight and with my magnifying glasses at 2.5 times mags, I can basically see what the burden is on top, and I can wash, irrigate such that the burden is going to be removed literally to essentially pathologic concentration. So again, the goal being the gold standard end block resection. So over here, I'm going to go ahead and start basically discussing some of the patients. These are all my patients that I've managed. You know, this nice lady came in with silicone, basically implant on the right side, and then saline implant on the left side. And as you can see, she has had a contracture. This is a mastectomy scar. And so the gold standard here is end block. As I'm going in, I'm mentally prepared. This is how I'm going to do it. I've boarded the patient not for an hour and a half, but for 3 hours, and basically making sure that I have that time window. Patient had a lot of chest pain, just hugging, for example, someone was a lot of discomfort. And so patient was taken to the OR. I started off with the right side. And as you can see over here, a lot of thickened and hardened tissue, what I would call grade 4 contracture. Very hard. As I made my cut, to my surprise, lo and behold, there is this biofilm / consistent with slime where there is this bacterial type burden. I'm caught by surprise because I was not expecting this. You would think that this would present itself to the surface. The patient has cellulitis, infection, patient is mounting a fever, chills, and as you can see right here, there is that creamy discharge. So I'm now all of a sudden, what do? I backtrack and I say, okay, I have to remove the capsule. I have to, now unblock is not going to happen because the implant has seen air. But guess what? The implant has to be removed. The entire capsule has to be removed. So someone who is in New Zealand who wants to do this, you have to remove the capsule. That's the take-home message. So what I do is I close it. Now I know what I'm dealing with. And purulent discharge, as you can see, it's angry tissue, hence the patient's presentation. Here's the capsule on the inside. I removed the implant. Here's the capsule on the inside, and you can see the chest wall, right? It's right on top of the chest wall, and it is very thick. If you can imagine taking sugar and putting it on native tissue and how the crystals form and passing your fingers on top of tissue, it's like sandpaper, all pathologic. And you can see, I tried to, there is the small amount of blood, but guess what? What do I keep telling myself? The capsule has to go. I start and see, look, the thick capsule must be excised. You see how thick that is? And look at the thinness from the skin to the capsule. To the untrained hand, I'm going to leave the capsule behind. That's what they're going to say. Because if you remove the capsule, you will inevitably kill the skin. you have to remove the capsule. I don't care. Because if you leave the capsule behind, you have done the patient a disservice. So the patient had history of breast cancer. I have to send the scar to pathology because this could be a recurrence till proven otherwise. The tissue was sent to rule out malignancy. This certainly could be recurrence. The fluid was sent to cytology to make sure this is not ALCL because the eyes don't see what the mind doesn't know. Microbiology cultures, fungal cultures, and then mastectomy scar sent to pathology. Everything. And guess what? I started on my dissection, taking my time. Here I am. I closed that mouth where there was the badness, so there is no spillage. This is the chest wall dissection with healthy, viable muscle remaining behind. Very difficult. As you can imagine, you have something essentially superglued onto the chest wall. That's what it is. Good, viable muscle. Bad capsule. Here's my hand, here's my retraction. Capsule removed without spillage of internal contents to the point where I said I'm not going to put drains because there was not a drop of badness that went into the chest cavity, because if there is, you're obligated in putting in drains, because now if you can imagine, you take a drop off a pollutant and put it in the chest cavity, all of a sudden that's going to grow on a petri dish, because that's the best petri dish, right, muscle, and it's going to basically become an abscess and a problem. Dissection done very meticulously, good muscle remaining behind, the entire capsule removed in its entirety without spillage of the contents into the chest wall. Very tedious dissection. And as you can see, nice, healthy, viable muscle after excision of the total capsule, total capsulectomy. No capsule left behind. And then this is another window right here, as you can see, nice, good breast tissue. Did you see that picture, that yellow crustiness? See that bad capsule all the way around? Just imagine you have to shell it out. All of that was removed as one entity, as you can see right here, I removed it, and you're going to see it. Let's go ahead and go back here. No drains inserted. Patient's actually right here with us in the audience, and she's smiling. No spillage of the internal contents despite total capsulectomy. No residual capsule left behind, and removal of the implant plus the capsule, what you would call the total capsulectomy. Not 90%. If I did the 90%, there's residual 10% that's continued trigger problem. Guess what? Here's the ruptured implant. Here's the total capsule. Entire capsule removed, ruptured. What would happen if I left some of that capsule inside? Infection, abscess, pus, fungal infection, possible cancer, God knows, because I don't know in the OR. I'm not sending it for frozen where the pathologist is looking at it within 15 minutes. So the entire capsule, I'll tell you this, I felt very good about removing it en bloc, i.e. not the en bloc, but as no spillage, because I dare not close the wound and expect any spillage into the chest cavity minus no drain, because that's only a setup for badness. And the patient did not get an infection because I felt very comfortable with my dissection. Very tedious again. So I have another patient, 82-year-old female, driving her car, ended up in a ditch, spun on ice, had a rupture of the implant. She came to me after she had the full workup by the trauma team. MRI showed a rupture along with basically a hematoma, which is a collection of blood, because she was on Coumadin. Thins the blood because the thinning of the blood is required, otherwise you might shoot a clot, you might get a pulmonary embolus, which means a clot, or essentially a clot that may shoot into the legs or into the brain and cause problems, or into the lungs that may cause disruption of the blood supply. So again, take-home message, removal of the capsule and the ruptured implant and the hematoma. Very tricky. Now guess what? This is like, you not only have to remove the implant, you have to remove the capsule, you have to remove the hematoma, which is the collection of blood, which is what we know from the MRI, and the patient's 82, and the patient has a liquefied hematoma, which means it's not clotted blood. It is essentially liquefied. It initially becomes coagulative and then becomes liquefied. And this, you have to send it out, again, ALCL, breast cancer, microorganisms, again, no drains, spillage of the contents that would deter, and again, patient did very well. Pathology, pathology, pathology. And so as you can see, this is the patient. Abnormal mass palpated. You're obligated in removing it. This is not the clot. This is the ruptured implant right out of the patient. And as you can see, seepage of the contents. This is very old first generation, second generation implants. So the goal of the surgery is removal of the implant plus the capsule and block. Number one, very important. Take-home message. Number two, check for any abnormal fluid. Send it to cytology. It could be ALCL. It could be lymphoma. And number three, any abnormal masses, send to pathology. This is a no-brainer slide. This is like the template. Because we want to gather, we want to get information, and we want to do the operation so that you have removed the burden of not only the implant, but the capsule and whatever it may have generated over the years. So this is the ruptured implant on this very nice patient. Very tricky operation, and I did the surgery, believe it or not, while the patient was on Coumadin. I just wanted to make sure her INR was not 5 or 4, because that may lead to unnecessary problems. But I wanted to basically, and I feel very comfortable with my dissection because of my nature of the dissections and experiences over the years. So I operate on carpal tunnel patients, for example, on Plavix. I operate on patients who are on blood thinners or Coumadin. I just want to make sure that the INR is not horribly high, otherwise this will lead to complications inevitably. These are relatively, and again, it's all that tedious, meticulous dissection that needs to be undertaken in order to be in the right tissue plane, so you get what your goal of the operation is. So ruptured implant with abnormal tissue, all abnormal tissue must be removed. Guess what? She gets a mammogram. She's heading towards an unnecessary biopsy because it was not removed. So this is another patient who had a ruptured saline implant. Residual yellow fluid. Now saline, as you know, is what they say the better implant to have, which it may be true, but at the end of the day, it's still an implant and it's a breast implant, so it comes with its own set of problems. So this implant ruptured, and you can see the residual fluid. I'm not going to toss it and be done. No. In my practice, I always tell the patient, take the implant home. This is yours. You never know. You can keep it, for yourself. And many patients come up with a list of requests, and I say, please do so, because you want to be the educated consumer patient so that you are prepared. Number two, I always send cultures for aerobic and anaerobic microbiology. Now, I try to push for that because what's the worst thing that's going to happen? You send it for nothing, but at least we know. I have sent cultures in my training on a patient, believe it or not, came back as TB. I was surprised. My boss was surprised, and I was like, wow, but guess what? When you asked the patient, she was overseas, she was on a mission, and lo and behold, she had basically indolent TB, and to my surprise, and I'll never forget it. But the bottom line is, so to send the implants, give the implants to the patient, that's very fair game. Number two, sending the cultures for aerobic, anaerobic, and fungal. Number three, sending any fluid to cytology, and this is the perfect example because again, the eyes don't see what the mind doesn't know, and you don't want to be sitting on ALCL, because what is lymphoma? Why did it happen? Because the body is mounting an immune response. It recognizes the implant as foreign, and it basically goes on overdrive, and all of a sudden the immune system goes on haywire, basically, and now the lymphoma / sign symptoms evolve. And luckily for this nice patient, there was no ALCL. It's rare, but a recognized entity, and hence friends stepping up and saying the textured implants are banned. So as you can see, it's very thick and viscous. It's like you're pouring honey. And you can see the drop by drop, and these are droplets. This is not liquid that will accumulate and drain. This is like honey and just settling in. This is silica, if you ask me. You know, I do not know, but they have to do their homework, the pathologist. And as you can see, it's accumulating on one side. And again, you see these are the droplets of this abnormal fluid, which needs and must be sent according to the standard of care. We want information. We have information. We want to make sure that we're not missing something. So dissection is very meticulous. Once I got done with my 6:30 case, I look at my assistant. I said, we have a fourth one today, and she's like, no, I'm done. Because it's about the retraction. It's about literally continuous movement of the shoulder, and you're making fine moves such that you're basically going and approaching this in a very thoughtful, systematic way. So you can, again, the punchline is removing the entire capsule and the implant and block.